Hi guys, welcome back to another video from the Aspiring Medics. As always, my name is Dr. Yusuf and I'm also the founder of the Aspiring Medics, and I'm also joined by...
Hi, my name is Harriet. I'm a medical student at Oxford.
Excellent. And in today's video, we're going to be doing an Oxford mock. This is going to be another tricky mock interview question, but I think it's important for you guys to get a realistic and difficult tutorial that you guys can also learn from. This is particularly going to be relevant for not only Oxford University, but also Cambridge University as well. So, like many, we're going to start off with personal questions, more of the soft skills, and then we're going to go further into some of the medical science as well. And the key thing to always remember in this is about how you're able to think versus as opposed to what you know. That's really important to remember. So let's get into it. In your opinion, what is the most important skill for a doctor to have and why?
Okay, well, I think there are a few different skills that are important for doctors. In terms of knowledge, I think it's important that doctors are competent. So they need to know when a patient presents a complaint, they need to be able to figure out what they could be diagnosed with, and they need to be able to take all the different cues that the patient is giving them in order to come up with the next course of action. But it's also important to balance that with empathy and kindness. So some patients might come in with a certain complaint but actually have something else in mind, and it's important that doctors are able to read that in their patients and be able to respond positively and empathetically in a way that patients are able to understand.
Good. So you think communication, empathy?
Yeah.
Great. Okay. And what about really in 2025 and 2030? What do you think is the most important skill? Do you still think it'll be communication, empathy with, AI and new advances with technology?
Yeah, I mean, I think even more so, because with the advances of AI, it'd probably be more likely that people are searching up their symptoms online, perhaps searching for remedies online, and coming into doctor surgeries with their own ideas of what might be wrong with them. So in that case, it's important that doctors are able to communicate. Active listening plays a more a bigger role in that, because they need to be able to listen to what the patient has come with, what their ideas and concerns are, and then respond in a way that is mature and takes the patient's ideas into account, but also lets them know what their professional opinion is. Yeah,
it's a really good point, actually. And the General Medical Council, the GMC, that looks after doctors, one of the biggest reasons for actual complaints for doctors is actually on communication. So yes, that's a very, very good point indeed. Okay, so it's crucial that doctors understand medical ethics. Do you think medical ethics can be taught or learned?
Well, this is an interesting question, because I think ethical values for some people is inherent. In terms of life in general, you think that your ethics are a set of values that you're not necessarily born with, but you grow up with, that you're taught by sort of parents and things. So I think medical ethics can be taught to some degree, because there are things that you don't know. There will be situations that you don't know how to handle at an age of 18, 19, that you'll have to understand with experience and time from peers and from colleagues and things like that. But there does have to be an inherent level of sort of kindness, empathy, I think, to understand, just a base level of humanity in dealing with situations.
Sure. So there's a humanity, sure, but really, is it really for doctors? Surely it's just, some red tape, some bureaucracy. It's not actually useful when you're practicing as a doctor, is it?
Well, it's quite important, I think, because as a doctor, you're going to be dealing with so many different people and situations that you probably won't even be able to come up with in yourself, things that you once experienced, that's experience you're never going to have again. So I think with every situation that you face, you'll learn more things, even if it's not sitting down in a classroom doing medical ethics, even if it's just on the job, in work experience, that kind of thing, where you see how doctors deal with different things. It definitely is a matter of learning and understanding things about yourself and about how other people deal with things as well.
Can you give me any specific examples?
So when I went on my work experience, I was volunteering at a care home for about 6 months, and there was a situation where there was an elderly woman with dementia in the care home. I was about to leave, but I think she'd bonded with me quite well over the day, and she didn't quite want me to leave, but she didn't understand why I had to. So in that situation, I had to go and ask one of the senior nurses for help, and she had to kind of restrain the woman while I was able to walk out. So I think it's quite difficult, because obviously people with dementia, cognitively, they're not as able to understand the situations as perhaps we are, and therefore you like getting consent for things like physical contact and things might be more difficult. So in that situation, you know, she had to restrain her perhaps against her will, but it was for reasons like she couldn't articulate her consent and things like that, and it was a difficult situation to deal with otherwise.
Sure. So you gave the example there of basically someone who's basically potentially might be getting a bit agitated, slightly physical. Can you think of any other sort of specific scenarios? Let's stick on with this sort of dementia, in which medical ethics becomes really important.
Well, if we think about sort of the pillars of medical ethics, things like there was another case where she's not able to eat sugar because it makes her diabetes quite a lot worse. So things like comorbidities and things like that. But like, I was going around giving out biscuits and things, and she really wanted one, but I was unable to give that to her because obviously it would make things harder for her in the long run. So in that situation, we're thinking about the pillar of non-maleficence. So as much as you want to do good and help people, you also don't, in the long run, that would cause her more harm. So
yeah, and obviously it's a very nuanced situation, isn't it? Because there are many situations that you'll face, especially in general medicine as a doctor, where you might have patients that are coming towards the end of their care, end of their life, but having dementia, they lack capacity. And therefore that becomes a big thing about where would they want to spend their last remaining days of their life? In hospital, in a hospice, in the house? Who helps to decide that? Are they, if they've got a swallowing problem, should they be able to have, if, you know, they're coming to the last few days, should they be able to have that last few biscuits or, you know, food that they would enjoy, just a taste of it? Or should that actually be nil by mouth, you know, the quote unquote safer option? So it's all a way up. So ultimately, do you think that medical ethics can be learned or taught, do you think?
I think it can. I think that as you grow as a doctor, medical student, that you gain more experiences and you understand how to handle different things differently. I think it's impossible to have like a full knowledge of medical ethics at like such a young age. And with most things, like you're able to gain like a bank of experiences that help you navigate different difficult ethical situations.
Yeah, absolutely. And it's a framework, you know, it's tied into obviously the legal system. It's also tied in just with professionalism and also hospital guidelines, regional guidelines, governmental guidelines and law. And that's also key things when it comes down to it. And ultimately, it's a different tool in the tool set, but that's ultimately why you have a whole ethics committee. That's why you've got a multidisciplinary team approach as well for that 360-degree view. So yeah, it's a really good point. Okay, so next question. What would you do in this medical ethics scenario? Your patient needs emergency surgery, but is refusing due to fear of the general anesthetic.
Okay, well, picking up part of the question a little bit. So if we start with patient, like I'm assuming that they're like an adult and are able to make these decisions for themselves.
Let's say it's a 25-year-old.
Okay, so like reasonably, like an adult is able to consent to things, and I presumably has been given all the information that basically without this surgery they won't be able to. Well, it's a life-threatening situation. Without this surgery, they'll die essentially. I think in this situation, you obviously want to talk them through it first. You know, a fear of general anesthetic is a valid fear, but you want to speak to them about the risks of general anesthetic versus the risks of not doing the surgery, and make sure that they're able to weigh up those two in the grand scheme of things. Like they're much more likely to not get through without surgery than to not get through the anesthetic, and making sure that you're empathetic in explaining that, and while you understand their fears, that there are greater consequences of not having the surgery than to have it with the anesthetic.
And so if we pause there, what would be one of the first things you'd want to do? So let's say it's a 25-year-old man, he's got this life-threatening appendicitis, it's spread to his abdomen, he's got this real infection and he needs surgery for it.
Well, first of all, you want to like communicate the gravity of the situation to the person. Obviously, this is quite a time pressured situation. So like in an ideal situation, you might want to bring family and friends involved, but that probably isn't possible in like such a short time frame. So it's just a matter of like explaining to him what the consequence of appendicitis is, making it really clear in sort of layman's terms. Like,
what does that mean? What's layman's terms?
So like basically, obviously doctors have their own terminology that probably isn't understandable to like the general public. So making sure it's in language that's clear, understandable to someone who isn't a doctor, essentially.
Fantastic.
And like talking, if possible, talking through the situation that made him fearful of general anesthetic, like what happened. Was it like a family member who had it and it didn't work out well? Trying to get to the root of the fear, and then trying to reassure him, maybe even bringing the like anaesthetist in to discuss how that will work as well.
Great, yeah. So again, it's worth clarifying what your role is, and who are you? You're the doctor there that's sort of admitting them in from ED, for example, from emergency medicine. Good. Actually, they have a fear because they had a really bad reaction to halothane 10 years ago in the dentist.
Okay, so obviously that fears come from their own personal experiences, which would make it quite difficult to try and convince them otherwise. But I think if we explain that the anaesthetic used in, I'm assuming the anaesthetic used in like the dental surgery would be different to the one used for this surgery, and that it would obviously if his reaction was quite bad, and that would make him have a difficult experience, but that this is it was quite a while ago, that things have progressed since then. And again, just like weighing up the risks of anesthetic versus not having surgery in the grand scheme of things.
So would you want to give him halothane? This thing that he had something happen to him 10 years ago.
Well, I mean, if there was an alternative, then I would propose that first before anything else.
So it might be worth exploring. What exactly was it? Was it like a rash? Is it like an allergic reaction? Is that on the system? Do you have an allergic reaction? Do you have any other allergies? That's something that we can take into account. And let's say he does have an allergic reaction to halothane, for example. What's next?
Well, I mean, obviously, if he's had an allergic reaction, then that's like, then giving him halothane would be a really like bad idea. So, so definitely looking for an alternative that is unlikely to give him an allergic reaction, and explaining that to him. Like,
good. So you're exploring that fear, understanding where is that actually coming from. Go on.
So yeah, like by delving deeper into the theory, you understand that it's more than just like a situation that's happened. Like, this is obviously an allergic reaction is as life-threatening as what's going on with him right now. So it's important to avoid like any further issues with the anesthetic, and definitely use a different one that's not going to give him an allergic reaction.
So you talk through all of that, and they still say no.
Ooh, that's tough. I mean, it's a really difficult situation, because obviously as a doctor you want to act in the best interest, but you can't especially with surgery, there's no sort of forcing someone onto the surgery bed. Like I said, even though it's a time pressure situation, if you could get like family members on the phone, potentially that could be more convincing.
Family members on the phone, no, still no. What else would you want to do in this patient?
I'm really not sure, to be honest.
Sure. So that patient with dementia, if that patient with dementia at that care home, you mentioned a C word before. What word are we wanting to talk about? For example, a patient with dementia might not be able to refuse treatment. Why? Potentially. Not all dementia patients, but some very severe dementia might not be able to. Why?
Because they don't have capacity to give consent.
Okay.
So I guess we could assess this patient's capacity.
Okay.
Because I think there are different components of capacity, and I can't remember them all, but one of them is the ability to weigh up information and come to like a reasonable conclusion.
Yeah. So that's like the third one. So it's being able to understand that information.
Yeah.
To be able to then retain that information, weigh up, and then communicate that decision. So can you talk to me about factors in this 25-year-old male with this severe appendicitis that could influence that?
Well, if we look at each of those parts, so understanding the information, we've said that we put it in layman's terms, so he should be able to understand it, and retain the information. So to check if he's retained it, we could ask
why else might someone not be able to understand the information?
Perhaps if they have like any sort of cognitive impairment, so they might not be able to understand it.
Good. Or what might someone have here?
Oh, like they might be like have a hearing impairment.
Good. They might have a hearing impairment. Good. Good. Carry on. Just in terms of the next, in terms of what can influence whether they can weigh up that information. If you just blitz through some examples.
Well, it depends, like how much information is given. So if they're given like an overload of information, they might not be able to weigh it up. Things like past experiences or like experiences of people around them that might
have medical causes. You also notice that they can't walk straight in a straight line. They've got a bit of a slurred speech.
Oh, so like if they've been drinking or like using recreational drugs or things like that.
So drinking, drugs. So those are some temporary causes that can cause it. What are other sort of more medical causes as well?
Like if they've had a concussion potentially.
Yeah, very good. Have they had a head injury? Good, well done.
I'm trying to think of other things that could have happened. Like if they've
gone.
I was gonna say like if they've had any like, I was gonna say cognitive impairment again, but that's like.
But it could be. So it could be, is it some sort of very early, surprisingly early, but this would be going through your checklist. Is it some sort of form of dementia? Is there some sort of electrolyte abnormality? Is there an infection that could be causing this as well, that can be causing this sort of confusion? So think about acute causes of confusion. Good. So that was really, really useful. That was quite a hard one, but I think it's a good one just to talk about and go through. So I'm going to go through this question next in the interest of time so we can move on to the real nitty-gritty medical science stuff. So the UK government has also recently set out to ban disposable vapes by June 2025. What are the benefits and implications of this ban?
Well, obviously vaping's been in the news quite a lot recently because a lot of young people, like adolescent, even like lower than that age, have been using vapes, and they were meant to be like an alternative for people who are smoking and then trying to like stop smoking. But now people just take up vaping for the fun of it instead. And although it's intended to be less harmful than smoking, the potential harms aren't like fully known yet. But like. Anything that's like you're inhaling into your lungs that isn't fresh air is likely to do damage. So in terms of benefits, like it's hopefully going to stop like their presentation in shops. So it's like looking at the image, like they're very colorful. They're definitely marketed towards younger people. So if they're banned, then they won't be like so easily accessible, hopefully, like in like big supermarkets and things like that, and therefore it's less likely that people will use them from like a younger age. I think
what are the consequences of vaping?
Well, it's probably going to be things like chest infections. It can be quite addictive. Like anything, it could like it's going to have similar effects to smoking, just without the sort of tobacco and like high level lung damage that smoking has.
Yeah. So again, we're still looking at lung damage, and as you mentioned, the sort of addictive part, especially in terms of the nicotine as well, and the fact that again, it's, as you say, it's not going to be good for your airways, and actually isn't better than just stopping to smoke as well. Good. Anything else?
Well, at the moment, I think it's like you're not supposed to have vapes until you're like 16 years old, but younger children are still able to access them. So if there's an outright ban, then it's unlikely that they'll be able to have those passed down and things like that.
What's also the thing about disposable vapes?
So like from an environmental standpoint, like impacting like climate change and things like that, if there are less of disposable vapes around, then it's going to have less of an effect on global warming. In the
there is that aspect. What else? So what are the, if it's there's disposable and there's what else?
Well, I'm guessing there'd be like long-term ones.
Yeah, more rechargeable, I'm guessing.
Okay, yeah.
So what would be a thing when we're talking about that in terms of potentially price that we'd be thinking about?
So it's likely that disposable vapes would be cheaper, more easily accessible than the rechargeable ones.
More easily accessible to who?
Like younger people.
Yes. And what do you mean by younger people, just to be clear?
So like mostly adolescents. There are
Yeah.
also some children less than like 10 who are using them.
Exactly. So that's the main aspects of this. And again, if we're able to prevent those guys from vaping, what's the benefit?
Well, well, obviously if they're children growing into adults like who don't vape, then it's unlikely that they'll pass that on to like the next generation as well.
Good. So that habit of smoking or vaping, for example. And what else? Something vaping can be described as a gateway. In what way?
So even though people like might intend to just only vape, it could lead them to smoking and other things that are more damaging.
Absolutely. And counterintuitively, the whole purpose really of vaping was to be a step down from smoking. But actually, loads of people see it as a step up from nothing. So yeah, that's really good. Okay, so we're now going to move on to the medical sciencey stuff now. All right. So here is a graph. Talk me through what you can see. What does this mean, firstly? What can you see?
Okay, so if we start with the axes, so on the x-axis, we've got a series of years in increments of 5 from 1950 to 2000. And then on the y-axis, it shows the number of deaths per 100,000 people for 3 causes that they've highlighted on the graph. So we've got the black line showing how many deaths were caused by stroke, the light blue showing how many caused by cancer, and then the dark blue showing how many caused by heart disease.
Good.
So well, looking at the shape of the different lines, so the heart disease one has sort of decreased over time, so less deaths have been caused by heart disease in more recent years. The line for cancer has stayed relatively stagnant with like a tiny increase maybe around the 1990s, but relatively stable over the years. And stroke has also decreased between 1950 and 2000, with like more of a plateau between 1995 and 2000.
So what has had the biggest decrease?
Definitely heart disease, from like 600 to about 300.
And what do you say about cancer?
It stayed relatively like the same level across the 50 years. So it's like 200 at the start, and then it increased a little bit in 1990, but at 2000 it's still around 200.
So what further information would you want to know?
Perhaps what caused that small increase in 1990? Was there anything in particular that caused that? Or maybe perhaps like split that into different types of cancer, because cancer is quite broad.
Right. And I guess one of the first questions also is, was there actually an increase? So it'd be interesting to have a look at the confidence intervals, right? And see where they lie as well, and see actually how often is this data? So do we have data points every year? Because obviously this has been smoothed out. So where are these data points that we're seeing? Really good. Okay, great. And you quite rightly highlighted that we're seeing an increase in probably cancer. Why? If I say that actually the line is like this and it carries on increasing, why?
Well, it could be like a number of factors. Things like increase in like obesity and things like that. That can be quite a major risk factor for cancer.
Good. Let's do some risk factors of cancer.
Well, for lung cancer specifically, smoking is a risk factor. Diet is a risk factor for a lot of cancers. Even just like gender, so obviously you're more likely to get breast cancer or ovarian cancer if you're female.
Sure.
Lifestyle, so like exercise, like carcinogens like UV rays and X-rays and things like that. They can also increase the risk of
cancer. We're thinking occupational, if we're thinking about like a demolition guy or someone back in the 1960s.
So they're exposed to like nuclear, like I can't remember what it's exactly called, but like in terms
asbestos, for example, like the lining. Yeah, like stuff like asbestos. Great. Okay, so those are fantastic. And so that's really, really useful, and well done for highlighting the trends there. So one of the things that it can also be down to is stuff like statins. What do you understand of statins?
So I know that they're a drug used to treat certain heart diseases, such as coronary heart disease. And I'm not entirely sure how they work though.
They reduce cholesterol. They're a cholesterol lowering medication. Cholesterol is one of the risk factors for heart disease. So we can think about heart attacks, ischemic disease as well within this, and cardiovascular disease, having a heart attack as well. So in short, a very basic analogy is, if you imagine your heart as a series of pipes, and those pipes are your blood vessels, if those pipes get clogged up, that is called atherosclerosis, and that inflammation in that inflammatory process contributes over time to increasing the risk of heart disease and also of a heart attack. Does that make sense?
Yeah.
So by lowering the cholesterol, it's lowering the amount of gunk, basically. Does that make sense?
Yeah, definitely.
Great. So talk me through this. I know we've got loads of information here. Just take 30 seconds just to have a look. And for those guys at home, please do pause this video. It's like you just to have a look at this and go through what you can see.
Okay. Okay, so we've got a couple of bar charts showing, well, we've got on one side patients with no known heart disease treated with statins for 5 years. So I'm guessing there'd be some, not quite a placebo group, but like a control group to compare, I guess, to patients who have had heart disease who are treated with statins for 5 years. And it's showing like, I think like how much they're benefiting from the statins. And like, so we've got 98% of them who with no heart disease didn't benefit from the statins, and then 96% who did have heart disease didn't benefit them as well.
Okay.
And then the sort of red, orange, yellow bar charts are showing like of those who benefited, what is it that they benefited from. So the people with no known heart disease, very few people had a stroke prevented, more had a heart attack prevented.
What percentage?
Oh, sorry, like 0.4% had stroke prevented, 1.6 had heart attack prevented. And then with patients with a known heart disease, there was like 1.2% who had like their life saved, and then 2.6% who had a heart attack prevented, and 0.8% with the
So compare that to the known heart disease. So what's the key insight there?
Well, that people who did have a heart disease were more likely to have their life saved than people with no known heart disease, and more likely to have a heart attack prevented and a stroke prevented.
Yeah, correct, exactly. So it doubles if you've got heart disease compared to not having a known heart disease. If you take a statin, you're twice as likely to get your stroke prevented. But again, it's still a very small amount, 0.8%. And ultimately, people see, what's the fact there? So about the life saved, 1.2%. What does that mean to you? Talk me through that.
I mean, it could be sort of like things like perhaps cardiac arrest, like that could be life-threatening. So it could have prevented that or made that less, like much less likely to happen. Other like perhaps things like angina, or like when you get heart pain essentially, or like a slowing of the heartbeat, or like an irregular rhythm of the heart. All of those things potentially could be life-threatening.
But it's not clear. It doesn't tell us what it's exactly from, is it? And like, would that then be included for stroke prevented or for repeat heart attack? It's not clear. What do you make of the fact that it's only a life saved for those with known heart disease? Does that make sense to you? Does that not?
Well, I think that does make more sense, I guess, because for people with no known heart disease, perhaps they are healthier and less likely to have had like a life-threatening condition. But even so, like, it is quite difficult to compare them, because like life saved is quite a vague sort of metric, and like it is unsure what was actually caused them, what life-threatening situation they've been under.
What do you think about the comparison of patients with no known heart disease and known heart disease?
Well, no known heart disease suggests that they could potentially have a heart disease and that it just hasn't been diagnosed, or it could suggest that they're just completely healthy. And the comparison is that like it's very similar numbers that have had no benefit. So 98% with those with no heart disease and 96% for those with the heart disease. So it does put the efficacy of statins into question, that so few people are actually benefiting from the drugs.
Good. Very good. So that's the key thing here. Are statins even worth using? If, it takes 100 people to have it every day, and then across, I'm assuming that this is over 5 years, only one life is saved. And anything else? We've spoken a lot about the benefits and about the reduced potential benefits. What else can we see? So we've spoken about the benefits and what always comes with when we're talking about any medication or any intervention in medicine.
Well, there are probably going to be some side effects.
Right.
And those aren't sort of mentioned in the graph, but
they are.
Apologies. Yeah, they're sort
of camouflaged, aren't they? But yeah, they are on there. Yeah.
So the upside down bar charts in light blue at the left of each pie chart shows the number of people getting diabetes and muscle damage, and the numbers are exactly the same for people with no known heart disease and with known heart disease. And the numbers of people getting risks are actually much higher than those receiving benefits. So 12% for each one compared to 2% with no known heart disease and about 4% for people with known heart disease. So it's just that they're doing more harm than good.
Yeah, interesting. So what did you do there? So what is it? So there's a load of questions about this data. You've said that there's 10% here for diabetes and 2% for muscle damage, and you've added them up to be 12%. And you said therefore that 12% of patients might have some harm.
Yeah.
Is that always going to be true, do you think? Do we know for sure?
Probably not, because there could be some people who got both.
Yeah, exactly. There might be overlap, right? Yeah. There might be people, as you say, they've got diabetes and muscle damage. It might be those that get muscle damage, which has you might say is a severe side effect. They'll also get the common side effects of diabetes. Yeah. So it's not clear, is it? Directly here. It's not also clear with the stroke prevented, repeat heart attack prevented, life saved. Is that in the same population or is that different? Is that saying then that in total 4.6% of people on the right, patients with known heart disease, are overall saved, almost 5%? Or is that actually saying only 2.6% benefited? And, so it's quite, that is something worth clarifying there. What do you think of saying known versus no known heart disease?
So it's slightly vague because known heart disease could mean with a heart disease that's undiagnosed, or it could mean healthy.
And what would be the next question if we say, well, actually they're saying it's because they're healthy?
Well, why are we giving statins to healthy people potentially?
Potentially, and what else? Maybe how do you define healthy? What was it? Was it a scan? And is everything as simple as saying someone's got diabetes, someone doesn't? What does medicine always work on?
Patient, their own opinions, I guess.
It is the world, is physiology, is black and white, is saying healthy, unhealthy?
Oh no, it's a spectrum essentially.
It's a spectrum. It's a continuum, right? So it'd be really interesting to sort of break this down further. Is actually with those with absolute zero, but again, atherosclerosis naturally happens over time. So what exactly is it looking at there? Is it looking at symptoms? Is it looking at non-symptoms? Is it looking at it from a scan perspective? Is it doing it from a blood test? And is it doing it by thresholds? And if so, what thresholds? That would be interesting to know. And, it was able to benefit some. So if you were going to use the statin, what also would you want to potentially consider?
How much of the statin is being given and how much benefit is what are the actual benefits? Because obviously we've got these vague metrics, but specifically how is it helping the people who are receiving the statin?
So what's that otherwise known as that you could then look at?
The efficacy of the drug.
So efficacy. So how are you defining efficacy then? What do you want to know instead then?
Essentially, we said that the statins are supposed to lower cholesterol. So is the cholesterol levels, how much have they lowered in the patient?
Fantastic.
And is that translating to obvious health benefits, like is their quality of life improving, that kind of thing.
Great. Is quality of life improving? Are they living longer as well? That would be interesting to have a look at. Really good. Well done. So how do you then design a trial on a drug to reduce heart attacks?
So whatever the initial sort of compound is, I think you test it on like cells, like isolated cells, tissues first.
Yeah.
And that's to check like how much of it is toxic. And then once you've got like an idea of the toxicity of it, then they move on to like I think mice is most common, but like testing on animals to obviously not, because the physiology of an animal is going to be different to human, but to get like a vague idea of how it could work in an organism.
Right.
I think it usually involves like inducing the disease in that animal as well.
Yeah. So what would that be in short?
Probably giving them like a diet high in cholesterol.
Yeah, or giving them genes to upregulate cholesterol, for example. Good. And then seeing does giving them the statin X dose for their body weight potentially then reduce the risk of cholesterol? And then so that's reducing the amount of cholesterol in their blood. What else would you be looking at? Like
how frequently or infrequently they're having heart attacks, but I'm not sure how you would be able to check that.
Yeah, a heart attack or a stroke. Good. Yeah. But let's say currently mice don't have heart attacks or strokes often. In a normal mice, it happens 0.1% of the time. What could you do as a model?
I'm not sure for this one.
So maybe you could increase the cholesterol to the point where it's then happening potentially more frequently, and then you could have okay, does this then prevent that risk, for example?
Okay.
Because otherwise you might have to have hundreds or thousands or of mice to have that same effect. Does that make sense?
Yeah.
Good. Okay, let's move on to this next one. You're doing really well. So what do you see here? Describe what you can see in this image.
So we've got an image of two sort of lower like beneath the knee.
Let's just have a look at the image just on the left.
Okay. So we've got someone like pressing into like the front of someone's like lower limb, and it's like it seems to be quite swelled up, like a lot of fluid in the leg.
Yeah. What else can you tell me about that image? Say what you see.
So the skin is kind of like discolored a bit.
What color?
Like so there's like yellowing around the ankles.
Yeah.
And like from the image, like when you press into it, like it's left like a mark.
Yeah, absolutely. It's left a mark here. Yeah.
Yeah. And similar on the left as well.
Yeah. Good. Well done. And you can also see some sort of like depigmentation. You can just see some whitish color here, some paler skin, and then you've got more sort of yellowish color, inflamed all the way through. And this is looking at which leg?
The left.
Of the individual?
Oh, the right leg. Sorry.
The right leg. Yeah, exactly. It's the right leg that we're having a look at and that we're seeing here. Good. Okay. Let's have a look at this graph. This is now, for the audience at home, this is now hard mode, okay? We've entered hard mode here, all right? So, talk me through just this red line here. What do you see here? What's this?
Okay.
Talk me through X, Y axis. What do you see in that red line?
So, we've got, on the x-axis, we've got ventricular performance. So, that's obviously relating to the performance of the heart, specifically the ventricles of the heart. At different like levels of exercise, so like at rest, walking and running, and then on the x-axis we've got the volume, so like how much blood is able to enter the ventricles when they relax and blood flows into them. So as like the level of exercise increases, for the normal person, that it seems the ventricular performance increases, and so does the ventricular end diastolic volume.
Good. So it increases linearly, exponentially.
It's not quite linearly, but it's linear at the start, and then it's sort of slow near the top a little bit.
Yeah, you're right. So from rest to running, It's still a bit curved, but it's basically linear, right?
Yeah.
At that point, it's basically linear. And then what happens?
It starts to like slow a little bit, so it curves more.
What starts to slow?
What starts to slow? The ventricular volume, so the amount of blood that's able to fit in the ventricles.
Yeah, so the gradient you can see is starting to become reduced, whereas at first it's quite linear, it's quite steep, it's reduced over time there.
Yeah.
Okay, good. And then if we say good, that's really good there. So if we then look at normal during rest, what do you see?
So the line is a very similar shape. However, it doesn't go up to the same level of ventricular performance as during exercise.
Yeah.
But it does have a larger volume. Like it starts further along the x-axis than the exercise, and it reaches like a higher ventricular end diastolic volume. Good,
well done. And if we look at this heart failure one, this one in purple, what's going on here?
Well, the graph hasn't even gone up to sort of like running level. So it hasn't even got, well, it's plateaued just beneath walking actually. So the ventricular performance is almost, I would say, about half as that at normal exercise level. And the volume of the ventricles is also higher, but I don't think that's a good thing by the looks of it. The gradient is a lot more shallow, and it like plateaus earlier, so the gradient gets more shallower quicker as well.
Correct, great. And this is really a first year level concept, but this is idea of contractility. Effectively, in short, we can treat it as being how well the heart is able to contract, okay, and how well the heart is able to stretch, and also how it's able to then also contract in response to that stretch. So the heart does stretch naturally, and to an extent that's going to be really useful, because at that point it's then going to be able to be at maximal position. It's to do with the muscle fibers as well, but it'll be in maximum position for a good stretch there to be able to maximally activate. So the more stretched to an extent a muscle is, the more effective it's going to be, in short. And we can just treat that as the definition for now for contractility. But what you can see, what is heart failure as far as you're aware?
It's essentially, is it when the heart just stops contracting?
So it's actually kind of a misnomer. So heart failure is actually what we're kind of seeing here. This is called lymphedema. This is leg swelling. There are many causes for leg swelling here, but you can see this fluid buildup and this fluid edema. And one of the causes can be a particular type of heart failure, where basically the contractility is really reduced, i.e. there's too much fluid buildup in the heart and the surrounding area, which then causes this problem in terms of heart failure, which therefore means that the heart is not able to pump blood as effectively around the body as it can. And that then means that there's this buildup of fluid that we're seeing in the legs. Does that make sense? So it's basically when the heart isn't able to pump blood efficiently. So the failure isn't from it stopping. It's not like that's it. It's a case of it's pumping, but just not as good as it used to. All right. And so over time, what can happen is that it becomes worse and worse. It becomes more and more fluid overload. And I'd say the stretch is good to an extent, but beyond a certain extent, the muscles far exceeds what it's usually used to, or its peak, and therefore means that the contractility is reduced. And what that means is, even by trying to get it to stretch, you can see that you're not able to get that same ventricular performance, that same effectiveness as you would in a normal heart. Does that make sense?
Yeah.
Good. So I'm going to go to this question here. What do you see in this graph?
So we've got pressure changes on the y-axis of diastolic pressure and systolic pressure.
What do those two things mean? What's systole? What's diastole?
So systole is, I think, when the heart chambers contract, and then diastole is when they relax.
Yep.
So during systole, like they've sectioned off the graphs into like systole and diastole, across. So during systole, the heart pressure increases, and there's two different lines, and one of them, the blue one, I think, is for the ventricles, and then the orange one is for the atria.
Yep.
So when the ventricles contract, the pressure increases, like from 0 like to above 120, and then during diastole it goes back down to 0, whereas the pressure in the atria remains between sort of 80 and 120, increasing during systole, but then going back down to 80 during diastole.
So what's going on? So walk me through it then. So now if we focus on the diastole, what's going on? So explain to me why it's happening.
So when the atria contract, like all the blood flows from the atria into the ventricles.
Yeah.
And then the ventricles
causes this big bit here. Yeah.
Yeah, and then the ventricles contract and all the blood flows out into, like, through the arteries to the body tissues.
Cool.
So as the blood flows in, that causes the pressure to increase. But then it flowing out causes it to decrease again.
Fantastic. Well done. Yes, exactly that. And that's obviously really important to take into account when we're looking at something like heart failure, for example. All right, so I'd like you to have a look at this graph, please. What does it show you?
So x-axis, we've got like a different like non-communicable diseases. Well, not necessarily diseases, but just like different lifestyles, I guess. And then we've got percentage of people, I guess, who have these diseases. Not diseases, lifestyle choices. And then we've got 3 different bars for each of the lifestyle choices, based on affluence. So, which is basically like how much, basically how wealthy a family or a group of people are.
Yeah.
So we can see that for people in general, for people with high affluence, they're less likely to be undertaking these lifestyle choices than people in low affluence. And well, that's the case for things like diabetes, hypertension. However, for obesity, people with low affluence are more likely to be obese, and that's likely because healthy food is more expensive than things that are unhealthy.
What's that called?
I've
heard the term food deserts, for example. So that's basically exactly as you're saying. Less socioeconomically affluent areas are unable to access that foods of high nutritious quality. Yeah, absolutely.
Yeah. And you can see that in the less than 5 servings of like fruits and vegetables a day as well. Yeah.
Good. So, what's these things? What's that called?
So I think that's like a standard deviation bar.
Okay.
And it basically shows like the range of the data. So I think if they overlap, then it means that the data isn't that dissimilar actually.
Yeah, good. So that's something that we want to have a look at. So it's not clear, is it the standard deviation? Is it just a massive range of all the data? What is the actual bar chart? Is that showing us an average of the data? Or is it actually, as you say, is it more of a standard deviation? If it was a standard deviation, just to recap, what does that mean? And if there is overlap, what does that mean?
So standard deviation is a way of sort of measuring the range of the data. And if the standard deviation bars for 2 adjacent bar charts overlap, that means that they're not actually that dissimilar and there's no significant difference.
Yeah, exactly. So that would be one thing just to clarify on this graph, and it's unclear, right? But you're absolutely right that otherwise what you see is that patients and people, citizens from low affluent areas are more likely to be diabetes, hypertensive, to not exercise, to smoke, for example, to have less than 5 servings a day. So based upon that, as our grand finale, based on the previous graph, what public health approaches would you then take?
Well, I think an important thing is making healthy food more accessible for people in areas of low affluence. So I guess things like working with like food banks or like other charities that support like more healthy options for people of lower affluence, like on a higher level, even taking it to government, things like that. Just highlighting the disparity, like if people aren't able to eat healthily, then that leads to more comorbidities in the long run, and therefore more NHS spending in the long run. So really it's better to tackle the problem at the root, which is like making sure that healthy food is more accessible for people who aren't able to afford it.
So prevention is better than the cure. So you want to focus on healthy and nutritious foods. How?
Well, things like in schools, like I know they do some like breakfast clubs for children. So they're having healthy meals before they go into school. I know in primary schools they have like free fruit at break times and things like that. For adults, like having like I said, food banks, or like more community-based like activities where like involving having healthy meals, like soup kitchens, things like that, where people can go and access healthier food, and trying to make them not too like making them more local as well, because that brings like it means it's like they can walk to the place, so it's more easily accessible, things like that.
So more accessible shops, for example, so go to nutritious foods that are available, local farms. Anything else? What did we mention? We said food deserts. We said nutritious food's expensive.
Yeah, so I guess
relative to sugary foods. So what are the two levers we can press there? So
then decreasing the price of healthier foods, whereas
what's that called? What's a fancy term for
that? I don't know.
A subsidy. So you can subsidize healthier, nutritious foods. Great.
Yeah. And then like increasing the price of more unhealthy foods. So I think
they've done that recently in the UK.
Yeah. So they currently have like a sugar tax.
Yeah, great. The sugar tax. Tell me more.
So it's basically I don't know the whole mechanism of it, but it's like essentially that foods with the like artificial sugars in them are more expensive. So there's like an additional tax on them to make them less desirable, I guess.
Great. So those are some of the key measures we mentioned about things like public health, greater public health awareness of it as well, that can also be useful. And there's been a lot, from couch to 5K, for example. And there's a lot also in terms of media and also media doctors to also play their part as well in helping to sort of spread this message as well, making gyms more accessible, etc., and subsidizing that. And we're also seeing something called social prescribing. Have you heard of social prescribing?
I think so. So I think it's like rather than prescribing like drugs themselves, like community outreach, like with the exercise. I know they do like park runs, so maybe encouraging people to go on those.
Fantastic.
Like other sort of community hub activities as well.
Great, awesome. So that concludes this Oxbridge interview. As I said at the start, guys, I think this was actually quite a difficult one. And we went through loads of content. So we went from like statins, we went through personal values, and we also spoke about heart failure. And again, the key thing is not about what you know, it's actually about how you communicate. And Harriet was absolutely amazing actually communicating her thought process. And actually, I was giving her new bits of information. She was able to use that really useful. And that's what it's about. It's about how you're able to synthesize content. And they may throw at you first year level content. It doesn't matter. It's about how you're able to approach it, how you're able to think about it, how you're able to structure your thoughts. So thanks so much for watching all the way to the end. We hope you found it useful. If you have, please do leave us a like, comment and subscribe, and we'll be back for more videos just like this. Thank you. Take care. Bye.